Good afternoon. I'm Josie Conti, Doctor of Osteopathic Medicine, and I am very pleased to be here with you today. Thank you so much for allowing me to share some of my thoughts and research on osteopathy in the older patient. I am going to now share my screen. See if I can get there all the way. Here we go. All right, so an osteopathic approach to the older adult, which will be followed by a lab. And when this airs on Sunday, June 13th, I'm going to be with my 86-year-old mom celebrating her birthday. I have nothing to disclose. This is gyras, and it came from a Greek vase, but he is the Greek god of age. His opposite was Hebe, the goddess of youth. His mother is Nyx, N-Y-X. And the word gyras, which means old age in Greek, or in some other literature, it means dead skin or the sloughing of a snake. And this word is the root of the English words such as geriatric. What is death but a birth from the second placenta to which life has been attached? If this philosophy is true, death is only the delivery of the furnished life whose perfection is far superior to the intellectual man, the maternal house of construction which is left behind. This quote from Andrew Taylor Still, Osteopathy Research and Practice. And I'm not suggesting that the older person or the patient or ourselves have one foot in the grave, but is reflecting a process that is varying in speeds from person to person after the childbearing years and onward. So the objectives of the talk right now is to review the qualities of the older adult population, help us to define who we're talking about when we say the older person, and also to help us provide holistic care. What does the literature tell us about OMT and the older person? And I would like to interject the 5 model concept throughout this lecture. It is a model that we are asking our graduate medical students, residents, and medical students as well to apply when thinking about patient care. I like to think about the 5 model concept when I put my hands on a patient, if I'm in the clinic, but especially in the hospital setting. It makes me understand and think about why I'm actually doing a treatment. But this includes biomechanical model, neurologic model, metabolic energy model, respiratory circulatory model, which is very critical, and behavioral psychosocial model. And throughout the talk, we will consider a patient and a couple individuals. Older adults now number more than 54 million people in the United States. By 2030, there will be about 72.1 million older persons, more than twice their number in 2000. 1 in 5 adults will be over 65. These seniors will live longer than previous generations, and longevity and old age are often accompanied by a variety of health challenges such as chronic pain, gait, and balance disturbances. You can watch Mom's gait. Whoa, she takes a little list to the side. Doing pretty well. She's got a wide-based gait there. Goes. Thank goodness for banisters and countertops. And here's my patient, LM, who was so happy to be included in the talk today. This chart, this graph, is a reflection on how our older population will become more diverse. So the dark color is in 2018, that's when this was made. And then the lighter color is going to be a projected 2060. And I really hope that the noise in the background won't be very distracting to you. But I cannot pause this because it's about the 5th time I've started to do this recording. So the older population is projected to become increasingly diverse, reflecting the demographic changes in the United States population as a whole during the last several decades. In 2018, 77% of the population there was non-Hispanic white alone, 9% non-Hispanic Black, 5% non-Hispanic Asian, 8% of any race. By 2060, it's projected that the change to 55% non-Hispanic white alone. There we go. I see my pointer, yep. And then 13% non-Hispanic Black alone, 8% non-Hispanic Asian alone, 21% Hispanic of any race. And although the older population is projected to increase among all racial and ethnic groups, the older Hispanic population is projected to grow the fastest. And this difference in relative growth has implications for the larger racial and ethnic composition of the older populations. For example, in 2018, the older Hispanic population was slightly, smaller than the older non-Hispanic Black alone population. It was 4.4 versus 4.8 million respectively. However, in 2060, it's projected to be larger, 19.9 million compared to 12.1 million. 80% of older adults now have at least one chronic health condition. 1 in 3 older adults has limitations in activities such as preparing meals and housekeeping. Data from the CDC on life expectancy at age 65 from 2018, 22.2% of non-institutionalized persons age 65 and older in fair or poor health. Men will live an additional 18.2 years and women 20.8 years. The leading causes of death among persons age 65 and older, number 1 is heart disease, 2 is cancer, 3 is chronic lower respiratory disease, 4 a cerebrovascular accident, and 5 is Alzheimer's disease, the most common type of dementia. It's important to note that provisional data has shown that the onset of COVID-19 has disproportionately impacted older Americans, resulting in higher mortality because older Americans are more likely to have more chronic conditions that contribute to an increased risk of death. But the US population is aging at a slower pace than many other developed countries. So we have 1980, 2015, and then projected to 2050. We have a variety of countries along this axis. So in the US, we have we had about 15% of our population at 65 and older. 2050, we're thinking 22.2%. But in Japan, they're projecting 36% of their population being 65 and older. In Italy, 35%. China, 28%. Compared to our 22. This is all projected 2050. In Mexico, 19% of their population projected 2050 will be 19%. And our older population is becoming more varied in so many ways. You'll see more same-sex couples being more openly present and accounted for. Many faces of our aging population. And what does age mean? It means how long someone has existed. We actually become dissimilar as we age, chronologically versus physiologic age. An 85-year-old out playing golf every day is not the same as the 70-year-old nursing home resident with multiple comorbidities, unable to perform their own activities of daily living. Aging is a cumulative effect of life. And I would like to share a reflection. So, what determines old? My 29-year-old niece was posting something to her social media fans about turning 30 in this coming December and feeling so old. So we have to throw that term aside, at least for this talk, because everything ages. It's merely a progression of time, and time is relative. Whoever started scratching marks on rock or wood must have done so with a chosen parameter. Maybe marking the moon through her cycles. That's sensible to me. Maybe sunrise to sunset. That's an increment of passing. But a full cycle around the sun, applying it to people, and then boasting about it one way or the other, that has got to be a Western idea. Okay, so I'm wondering now, who decides when someone's old? Old enough? Old enough for what? To carry a weapon? Old enough to die for your country? Old enough to purchase cigarettes or alcohol? When do we categorize people into categories? Why do we do that? You're young. You're old enough? You're too old. My mom, turning 86, as I said, she has stage 4 cancer, and it declared its presence in August 2017. She had 75% of her stomach removed and was sent home on hospice with a G-tube. She and my father seemed to be having a race to some finish line. My father won. That's my mom, after her surgery. But my father won the race, and in January 2018, after a second stroke, this one really massive, he was on life support for 36 hours, and when we carried out his wishes, he completed his passage 6 hours later. I was bedside, but Mom was being home and cared for around the clock. She is a survivor. That's a later picture. A true reflection of her resilience, developed as an orphan child at 4 months of age. She was spunky, the messiest child in the group, my grandmother said. At age 4.5, she was adopted into a loving couple's home. But I digress. And that's okay. It's part of age. You have a collection of all of life's twists and turns in you, marking you. So her first vaccine left her encephalopathic, and she was brought to the emergency room for a $20,000 workup. She cleared by evening, fearing her second dose. I promised to be there to support her through in case she had a reaction again. In our older patients, a simple vaccine can throw all functions for a loop. This is just pictures of my mom. She was always spunky. She continues to be spunky. Spunky is kind of a rude word, so I would say please don't use that with your patient population, but she's my mom. She would call herself spunky too. This is the most recent photo. But aging symptoms means alterations of organ function, and parts just wear out. Joints often go first. Hips, knees, in our 50s, in our 60s. And to keep ourselves active, we agree to have our parts sawed off, and in comes metallic ceramic replacements. The other option my orthopedist tells me is we give you a cane and maybe a walker and say, good luck. Internal organs can be replaced, parts removed, like stomachs, intestines, a kidney. But lungs, for an example, unless there is an autoimmune process and a person is young enough, well, lungs will reflect habits of toxic exposures, COPD, emphysema, mesothelioma, hearts too. We can have our vessels rotor-rooted, stents placed, rerouted vessels and valves, chests cracked open, ribs splayed, lots of patchwork, and cardiopulmonary rehab. The strong-spirited will rehabilitate and get moving, and the more sedentary will lose recoil of their ribs, of their sternum, and this will affect their diaphragms and their posture and their general mechanics. We've seen patients with biomechanical changes like this, but biomechanics is just one of the 5 models that we're going to be discussing in a little while. So what's in a name? What's old? There's many classifications. So in general, we agree that 65 to 75 is a young old. 76 to 85 is old. And 86 to 120, so on, is old. And we say elderly when we mean more frailty, and we also use the term geriatric when we are talking about more comorbidities that manifest. This is from the CDC Goals for Older Adults, Healthy People 2030. So here's some of our goals. And as primary care providers, which many of us are, we might want to be thinking about how do we help this out? How do we increase the proportion of older adults with physical or cognitive health problems get physical activity? How do we reduce the rate of pressure ulcer-related hospital admissions among our older adults? How do we reduce the rates of admissions for diabetes among older adults? So a lot of this sounds to me like diet and exercise and compliance and seeing them often. What about dementias? That's another concern. I'm going to move myself up there. There's how do we increase the proportion of older adults or their caregivers who know that dementia is there? How do we reduce the proportion of preventable hospitalizations in older adults who have dementia? How do we increase the proportion of adults with subjective cognitive decline who have discussed their symptoms with a provider? We have to ask the questions, and we need to take it seriously. Other concerns for our older patients, our older folks or populations are reducing infections caused by Listeria, or for an example, so better refrigeration, fresher foods, access to fresh foods, improved digestion, maybe PPIs and suppressing the GI system's natural abilities to fight infection as a first-line defense. Maybe we need to improve that. And also for infectious disease, how do we reduce the rate of hospital admissions for urinary tract infections among our older adults? Here's a few more. How do we reduce falls related and fall-related deaths in the older population? Or how do we reduce the proportion of older adults who use inappropriate medications? How do we reduce the rate of emergency department visits due to falls among older adults? And what about oral conditions? How do we reduce the proportion of older adults with root surface decay? How do we improve dental care? Maybe looking at the teeth as part of the head, as part of the whole body, as part of the system, as part of medicine, and covered by insurance. What about reducing the proportion of adults aged 45 years and older who have lost all their teeth? And that leads to increased height, actually. When you lose your teeth, then the temporomandibular jaw relationship to the cranial base and the cervical region starts to move forward, and we have postural changes. What about reducing the proportions of adults age 45 years and older with moderate and severe periodontitis? Again, providing more care, having more dental clinics, training more people, more toothbrushes, more awareness, part of our exam. What about osteoporosis? How do we reduce hip fractures among older adults? How do we increase the proportion of older adults who get screened for osteoporosis? And how do we increase the proportion of older adults who get treated for osteoporosis after a fracture? I am trying to turn on my timer so I know how we are making progress here. What about respiratory disease? How do we reduce the rate of hospital admission for pneumonia among older adults? And how do we reduce hospitalizations for asthma in adults age 65 and older? And as far as sensory or communication disorders, how do we reduce vision loss from age-related macular degeneration? These are concerns of the CDC and public health concerns. These are my sandals. Why do I have them there? My sandals are light brown. They must be 8 years, 10 years, maybe older. I don't grab for them all the time because they're open-toed and I really can't wear them to work, but they fit so well. They have conformed to the shape of my foot, and being leather, they have conformed to my gait, to my stance, all reflected in the bend and the curve of the leather. But turn them over and they are cracked. They're dried out. They're falling apart, and they leave little chunks of plasticky cork along the way. They remind me of the body, just the body form in general. My body, the aging body. The body reflects life. What has been seen, what has been experienced, mastered, abused, misused, that too. Years back, when I was a massage therapist, I had a client who was a master lute player. That is not a picture of him, but it's a painting by Valentin de Boulogne. But he came monthly for body work and to have me help him with his back pain and his neck pain. His posture, his position was leaning slightly to the left. He had an increased kyphotic curve through the thoracic region, a right side bending of the neck so he could see the strings. He had a rotated torso to the left. I could imagine how his instrument fit into the curve of his form. I can't undo 25 years of his melding with his instrument, not in 45 minutes, not once a month, not even once a week. No. This was how his body adapted to serve and become one with his instrument. And we do this as we do. We become as we are, as we do. It takes a lot of dedicated time to unsit and to unhunch. So sit up. Breath makes it possible. Daily personal commitment to open and reverse and undo. Bones bend, muscles shorten or lengthen, fascia deforms, becomes dry, reforms, adjusts. So over a long lifetime, the body reflects this. Osteopathic philosophy and guiding principles for clinical care. The human being indeed is a triune of body, mind, and spirit. And I feel like I found with many of my elder patients is a real spirit shining through. Because you cannot be a sissy in age. I mean, you really, it's a privilege to find ourselves in older age. We also need to remember that structure and function are interrelated. As we use our bodies, so will function reflect. And the opposite is true as well. So we have a flattened diaphragm, for an example, then that's going to change the way we are able to use our respiratory function, muscles, and diaphragmatic excursion or not. That's going to affect internal organs. But then again, that's the 5 model concept as well. We all have the capacity to self-regulate. Health is a natural state of harmony, and disease is a confused nature. So when we identify somatic dysfunction, we're actually seeing a process of the body fixing itself. It's so important to remember that when we're treating. Precise physiologic adjustment of the organism can facilitate the return to health. So the 5 model concept. The 5 models of osteopathic patient care represent an anatomical and a physiological approach to the patient. It was developed by the Educational Council on Osteopathic Principles of the American Association of Colleges of Osteopathic Medicine and approved by the Council of Deans in 1987. In 2006, the World Health Organization recognized the osteopathic 5 model concept as a unique contribution to world health care. And in graduate medical education, as we educate our medical students as well as our residents, we have milestones that we are measuring our residents' progress by, and that includes the 5 model concept. So I feel that when I mention it to older generations, that term is not familiar or probably know it inside and out, but you may not use this language. But I do want to apply it today. So here's 5 models. There's also a suggested 6th model that is more intuition, but that is for another lecture. But we have the biomechanical model, the neurologic model, respiratory circulatory model, metabolic endocrine model, and the behavioral model. So let's see how these might expand in our application. So biomechanically, by improving the balance, by addressing the muscles, bones, fascia, we increase range of motion that can lead to, my face is in the way, to ease in motion, and in turn will reduce pain, lead to less need for pain medications, and that will lead to less interactions with other medications. So stresses or imbalances will lead to increased energy expenditure. So when you are not walking with the most lifted posture, you're using a lot more energy. There's also changes in joint structure, and that has implications. There's impediment of neurovascular function and altered metabolism. So we would apply techniques to improve general range of motion and balance. The fascia is the place to look for the cause of disease and the place to begin the action of remedies in all diseases. By its actions, we live, and by its failure, we die. Andrew Taylor Still, Philosophy, Mechanical Principles of Osteopathy. The neurological model correlates to the head and organs of special senses, our ability to taste properly, or smell if a food is good or not, or if there's smoke in the room. The brain, the spinal cord, the autonomic nervous system, and the peripheral nerves. So reducing sympathetic drive affects the hypothalamic pituitary adrenal axis. Polymodal afferent activity can summate to exacerbate, maintain, or initiate changes in function at the level of the spinal cord, the brainstem, and the cortex. And applying osteopathy in the cranial field to the full body, including the head, cervical, thoracic, lumbar, and pelvic regions to enhance the neurologic function. Cerebral spinal fluid is the highest known element that is contained in the human body. And unless the brain furnishes this fluid in abundance, a disabled condition of the body will remain. He who is able to reason will see that this great river of life must be tapped, and the withering field irrigated at once, or the harvest of health will be forever lost. Andrew Taylor Still, Philosophy of Osteopathy. I will only hint and would feel embarrassed to go any farther than to hint to you the importance of an undisturbed condition of the 5 known kinds of nerves, namely sensation, think of that as proprioception, motion, nutrition, voluntary and involuntary, all of which you must labor to keep in perpetual harmony while treating any disease of the head, neck, chest, abdomen, pelvis, spine, and limbs. Andrew Taylor Still. The third model, respiratory circulatory model, we apply this model a lot in the inpatient setting when treating with osteopathic manipulative medicine by improving the flow of lymph, arterial and venous blood flow through the system, moving the diaphragms. The integrity of the respiratory circulatory system is influenced by postural changes. On a microscopic level, this occurs through the tissue stress, and macroscopically through respiratory mechanics. There's 3 ways that we can move lymph. We can breathe, we can laugh, cry, through voluntary muscle movement or manually moving it. Work central to distal. The thoracic inlet, then the thoracic cage, the thoracic diaphragm, the pelvic diaphragm, and plantar aspects of the feet. No rule, but just a suggestion. The diaphragm says, by me you live, and by me you die. I hold in my hands the powers of life and death. Acquaint now thyself with me, and be at ease. Andrew Taylor Still. Philosophy and Mechanical Principles of Osteopathy. And the rule of the artery is absolute, universal, and must be unobstructed, or disease will result. Andrew Taylor Still, Autobiography of Andrew Taylor Still. The fourth model is a metabolic energy model. The human body requires a balance between energy expenditure and energy supply to maintain homeostasis. So efficient operation of internal body systems conserves energy that can be used and adapt to nutritional deficiencies, to trauma, infection, and nociceptive stimulation. We want to address the internal organs, endocrine glands, metabolic processes, homeostasis, energy balance, regulatory processes, immunologic activities, and inflammation and repair, digestion, absorption of nutrients, removal of wastes, and reproduction. For an example, improve the bowel function. And last and very important, critical, is the behavioral model. Psychosocial aspects of an individual's life influence their health status and their ability to compensate to health stressors. I'm thinking about inequalities, disparities of health, disparities in distribution of resources. Also, activation of the HPA axis under stress. The simple perfection of human touch, the mother of all senses, reducing stress of isolation. Address the psychosocial factors of isolation and the drought to touch. Touch your patients and don't be afraid. Here's basic comorbidities challenging the older population, and just reframing with applying a few of the models. For an example, polypharmacy. Polypharmacy is going to be affected. We can think about the metabolic model. So pharmaceuticals need to go through process through the liver or the kidneys. Biomechanically would be affected if there's polypharmacy in a bad way, because it might lead to falls. It would also suppress the respiratory drive and the respiratory circulatory models. See? What about mobility and activity issues? That's another comorbidity challenging our older population. So that leads to biomechanical and structural changes. Smaller steps, less gait, neurologic changes, less information coming in, less proprioception being stimulated at the bottoms of the feet. Metabolic model, how we're able to actually use the food that we take in, because we need mobility and activity that helps us along. Respiratory circulatory model, moving the legs. The feet are like a windlass, right? They spring, and we spring through the arches, and that spring also is reflected through all the diaphragms. And the behavioral model is challenged when you have mobility and activity issues, that you become depressed when you can't do the fun things that you like to do, or you see your friends doing things that you would like to do, and you are fairly sedentary. And caretakers, finding them or being one, affecting a behavioral model. This one stands out to me: financial and access issues, another comorbidity challenging our older population. So there's disparities and inequalities among people of color, among aging people, among our veterans. That's the behavioral model. What about nutritional issues? That's an obvious metabolic model issue, taking in energy. Maybe your appetite's not so great when you get a little older, or maybe your sense of taste doesn't drive you to want to eat nutritious foods, or maybe you don't have teeth and so you are not breaking down food the way you really need to. Those are all nutritional issues. So is changes in your senses. That would also affect the way that you're able to take food in, and the proper food. So you may not know when your food is spoiled. There's compliance and confusion issues. That would be in the neurologic model, your ability to have clear cognition, as well as the behavioral model. And also sensory changes is another comorbidity challenging the older population. We need glasses. Our hearing changes. We have a diminished sense of smell sometimes. We have less proprioception coming in through our feet and our hands. Our sense of taste has changed. So neurologic model, but also metabolic. You can see how everything is interrelated. This is a big chart. I'm not going to read. If you want a copy of this, I would be very happy to send this PowerPoint off to you. I'm going to post my email address at the end. So getting back to psychosocial and risk factors for the elderly or for our older patients is ageism. There's prejudice and discrimination directed toward people, either on the basis of their chronologic age or symbol of age, such as gray hair or wrinkles or having a slow gait or a limp or using a cane. The elderly are seen more frequently in doctors' offices. They have shorter visits because you rush them through. I don't say you as an individual, but in general, they get processed through. Maybe the questions are not asked that really need to be asked, and they're prescribed medication more frequently. That's going down the wrong route. Also, fostering of dependence rather than independence. My mom, she still lives on her own. And sometimes I wonder if she needs a little more help around the house, but her apartment rather, but our culture tends to foster dependence, right? Just the way we are telling people they're there, or you sit still, or let me do that for you. That's ageism. There's decreased social support. Many elderly and older people have parents and spouses and siblings and friends who have passed. They're socially isolated. And boy, this past year and COVID has been a brilliant reflection on how isolating it can be to need to stay in. And when you're on your own, when you're older or not living with other people, it's really leads to a lot more depression. Cognitive impairment dysfunction in any single function or combination of perception, thinking, language, and memory. That's other psychosocial risk factors. And an erroneous stereotype is that any cognitive impairment is a result of normal aging. So we need to change that. So as a result, it is estimated that up to 80% of our older people have encephalopathy that goes undetected. So when a patient says, I feel like my memory is going, and you say, oh yeah, mine too. No, you need to ask, what medications are you taking? And tell me more about that. What do you mean? Can you, go ask those questions. If you can't, is there someone in the office who can spend some more time with your patient? Mobility, biomechanical model affecting everything else. Mobility is fundamental to everyday life, central to an understanding of health and well-being among older populations. Impaired mobility is associated with a variety of adverse health outcomes. As the age of the U.S. population continues to increase, aging and public health professionals have a role to play in improving mobility for older adults. That might include more ramps. There are critical gaps in the assessment and measurement of mobility among older adults who live in the community, particularly those who have physical disabilities or cognitive impairments. By changing physical environments and creating unique integrated interventions across various disciplines, we can improve mobility for older adults. Falls resulting in injury. So each year, 1 of 3 adults age 65 or older falls. Falls can cause moderate to severe injuries such as hip fractures or head traumas and increase the risk of early death. Among older adults, falls are the leading cause of injury and death. They're also the most common cause of non-fatal injuries and hospital admissions due to trauma. Many people who fall, even if they're not injured, develop a fear of falling, and then this fear can cause them to limit their activities, and that leads to reduced mobility and loss of physical fitness, which in turn increases their actual risk of falling. How are we going to help them? Well, Tai Chi is a beautiful exercise. Qigong is a beautiful way of moving, being on your feet. It's fairly ageless. You can sit in a chair and do Qigong, gentle stretching, older age focused exercise classes. Yoga can be adapted for any body and any ability. So how much activity do we need as older adults? 2 hours and 30 minutes, 150 minutes a week of moderate intensity aerobic activity like brisk walking. Every week, muscle strengthening activities on 2 or more days of that week that include all major muscle groups, legs, hips, back, abdomen, or 1 hour and 15 minutes, 75 minutes of vigorous intensity aerobic activity every week, and muscle strengthening activities on 2 or more days of the week, or an equivalent mix of moderate, vigorous intensity aerobic activity and muscle strengthening activities on 2 or more days a week that work all major muscle groups. A great example of postural changes. Big kyphotic curve, forward head carriage, center of gravity no longer where it used to be, sacrum's tucked under. Gravity causes stress on the shoulder capsule and tendons of the hanging arm. Those pectoral muscles become very tight. Forearm flexion, abduction cause friction with the overlying ligamentous structures when you're forward like that, predisposing the older individual to developing degenerative tendinitis, bursitis, or osteoarthritis, and resultant pain and decreased range of motion. The sacral base shifts forward in relationship to the pelvis, causing vertebral compensation by increased lumbar and thoracic curves. The resultant weight-bearing strain on the iliolumbar ligaments can cause chronic low back pain. So this is what the literature tells us. And at the end We have some references if you want to see the full studies. But in general, there's significant difference found in length of stay in the hospital for those older people hospitalized with pneumonia who were treated with OMT, and a significant difference found for duration of IV antibiotics and death or respiratory failure in those who received OMT. Therefore, OMT is an effective adjunctive modality. Thank you, Dr. Knoll et al. Adjunctive OMT may reduce length of stay and in-hospital mortality rates in older adults with more severe pneumonia and lower ventilator-dependent respiratory failure rate than with the regular care folks. Dr. Knoll, a different study. Head turning is needed. Head turning is indeed an important cause of sudden drops in blood pressure with elderly with carotid sinus hypersensitivity. Right. So, yeah, sometimes people get dizzy and lose their balance because of the changes in the relationship of the not only on a bony level through the cervical region, but also compliance of vessels. OMT protocol used in the present study in this improved the postural stability of healthy elderly patients as measured by changes in sway value. Dr. Lopez. So they did studies on OMT and reducing imbalances. Abdominal massage increases the number of bowel movements, the stool weight, and stool consistency, decreased mean scores for straining, and decreased inability to completely empty the bowels. So gentle lifting of the colon, nice visceral treatment to improve bowel function. Twice monthly OMT and light touch protocols reduce the number of hospitalizations and decreased medication usage in elderly nursing home residents. After treatment with 7 stages of Spencer, those who received OMT demonstrated continued improvement. In their range of motion, while range of motion in the placebo group decreased. Significant improvement in pain relief and quality of life in hospital geriatric oncology patients during osteopathic manipulative treatment. Don't be afraid to treat your patients in an indirect manner. And in case you are wondering about trends of osteopathic physicians and treatment, in a national survey by the AAO, various OMT techniques were used to treat patients in the 3 age groups. They grouped patients into, like a younger, into younger patients, middle-aged and older. However, high velocity, low amplitude, HVLA, was usually avoided in patients age 65 or older. And then characteristics and treatment of older patients at an ONMM outpatient clinic reviewed 9,155 total encounters for 1,238 unique patients presenting for neuromusculoskeletal concerns associated with back, neck, and extremity conditions, consistent with national epidemiological data for this population. The most common OMT techniques were also consistent with those used nationally by osteopathic medical students and practicing physicians. Muscle energy was the most documented, while HVLA was the least. So considerations for our older patients. Here is Dr. Herman and myself treating Mr. C, and he was a patient of ours. I wrote to his daughter and I asked, can we use your dad's photo? Because he was part of our patient population and was featured on a brochure. He said, she said, absolutely, he would love to know his photo was being used. And OMT made him feel so much better. And I think just the human touch aspect alone is also quite healing, especially with the elderly population. And she is spot on. Osteopathic manual treatment is a form of drug-free manual medicine. I know I'm preaching to the choir, but let me just say it. Focused on the musculoskeletal system, lymphatic and circulatory systems, and the HPA axis to support inherent self-regulating, self-healing mechanism and help bring the patient to a more balanced state. OMT is an adjunct procedure available to all patients by a trained physician in their primary care clinic. We hope by referral to a specialty office, and is in many hospitals around the country. OMT as an adjunct has been found to improve immune function, improves pulmonary function in elderly patients with pneumonia, reduces the incidence of ileus in patients who have had abdominal surgery, and therefore reduces length of hospital stay. It's generally tolerated well, and it's found to be safe. And inquiring consent is very important. And if a patient needs an advocate to consent, this would need to be documented. So that is one of the challenges in working in the hospital setting with very elderly patients who may have cognitive changes. So if OMT seems like it would be helpful for them, please get permission or talk this through with one of their representatives. Here's LM. She is 93 and she has osteoporosis. She just came to see me yesterday. Oh, let me back up. She became a patient of our clinic in 2018 because we met her while she was hospitalized after several compression fractures. And she continues to have OMT. She had 7 thoracic fractures, spontaneous metatarsal fractures, spontaneous ankle fractures. She has a history of atrial fibrillation. She's on Coumadin. She has peripheral arterial disease, altered activities of daily living and skills. She has chronic low back pain, and she lives alone. And she prepares her own meals. And she uses a walker at home. She has 2 grown children in their 70s who check in on her. Here she is seated. It's difficult to see from this angle, but she's quite compressed through her torso. This is her standing, and you can see her kyphotic curve slightly rotated off to the right. See more fullness here. We'd like to make sure that we're addressing her with the 5 model concept. And positioning is going to be really important for my patient and your patients who have altered postures to how best to help them to be as comfortable as possible. So when I saw her 3 weeks ago, she could not get out of her chair. I needed to pick her up by the seat of by her belt, basically, and her son helped her out of the chair onto the table. And she has edema of that left leg. She had a melanoma on the lower left leg and had a Mohs reconstruction there and altered circulation. But she also has a pacemaker, and she has altered respiratory circulatory function and atrial fibrillation. So she has a lot going on, and her mind is so intact. The goals of osteopathic manipulative treatment for our older population is to return the patient to a degree of independence in daily activity. So one thing I did after I saw her 3 weeks ago was I asked for physical therapy to start coming to her home. We also ordered a hospital bed. I want her to be as strong as possible, but I also want a set of eyes at home to see, can she be at home? And does she need, does she have the railings available and the equipment she'll need to help her to stay safe? Another goal is to prevent secondary disabilities, to restore functional ability, to prevent succumbing to multi-system diseases. As you can see, we need her diaphragms to be working as optimally as possible. We want to help with postural drainage. We want to help her respiratory system function optimally. We want to stretch the tight fascial sheaths. We want to mobilize fluids, blood, lymph, cerebrospinal fluid, urine, digestive fluids. We want to help her digest and eliminate. We want to help relieve pain. We want to restore and maintain autonomic balance. And we want to increase the patient's feeling of well-being as well as preserve energy. Now, let's go back there. I cannot change that curve, but I might be able to improve upon her ability to lengthen through her spine by giving her some instruction and by using my hands. And also by physical therapy and what she does every day, most importantly, and using conscious breathing. Here's some relative contraindications: the condition, contraindicated technique, and the alternative technique. So in joint synostosis or osteophytic bridging, which she has a lot of, we're not going to do thrusts. Maybe be very careful of muscle energy, but you can do indirect treatments. How about joint barriers which feel hard and is painful? No thrust techniques, but maybe indirect techniques. What about vertebrobasilar insufficiencies? We want to avoid the AA thrust or muscle energy in the OA-AA and treat indirectly. And the same with people and of any age with rheumatoid arthritis, especially in a flare. No thrusting of the AA joint, and instead use an indirect technique. But so just one approach is that we want to position her or him to comfort. Treat the diaphragms. Treat the thoracic inlet. The abdominal diaphragm, the popliteal fossae, plantar fascia, the OA. Treat the fluids. Restore balance of the autonomic nervous system. How would you do that? Maybe through suboccipital release, maybe by osteopathy in the cranial field approach in general. Improve the mobility of large joints and small joints. You can do this really carefully with range of motion. Be very attentive to the barriers. You want to go to the feathers edge of the barrier and not miss that. How about some rib raising? That was a tough one for her because she has pain in her ribs because of previous compression fractures, but we can still get her ribs moving a bit. And then gentle visceral release. Maybe not necessarily that order, you'll do what makes sense for the patient who presents to you. Here is a hospital protocol for OMT to see if we can reduce delirium or encephalopathy in our aging patients, in the elderly. This was a design from 2015 in a project that Dr. Sutherland, Dr. Melmadrona, Dr. Herman, and I worked on. And we wanted to try and optimize diaphragmatic treatment. The plantar fascia, maybe we would do myofascial release, thoracic inlet, cervicothoracic myofascial, or BLT, BMT rather, balanced membranous tension release, thoraco-abdominal diaphragm treatment with myofascial release, pelvic sacroiliac region with sacroiliac myofascial release or lumbosacral myofascial treatment. With the osteopathy in the cranial field, this is just a protocol, a suggestion. We were wondering, can we make sure that we include an occipitomastoid suture V-spread, enhance motion of the vagus nerve and function of the vagus nerve, frontal release, lift, parietal lift, treating the autonomic nervous system with rib raising and sacroiliac decompression. And I think we might be losing a little bit of that, but that's okay. My last piece. I can't keep the sun from rising and setting, the moon from cycling through her many phases, seasons from coming and going. Oh, summer, you're almost here. In 2 weeks, we'll see the longest day of the year, the most sunlight compared to night. And after this, we slowly move away once more. Is it me, or is time speeding up? Soon autumn, leaves flying, caught in little eddies, swirling and lifting and trying to jump back up to branches of trees who cannot reattach them, but who are retreating life force down into their roots and into the earth. And celebrations of harvest, and eventually to the longest and darkest day, winter solstice. No wonder we drag a tree inside and cover it with lights to brighten our dark days. I can't keep time from rolling along, as I cannot keep my children close to me and in my arms, tucked into a cozy bed beside me, a tangle of arms, of legs, one on the left and one on the right, one asleep and one whispering, "Tell me again about." No, they can't turn back. Do they even want to? Does it ever come to their minds and hearts to crawl back in under the covers and snuggle deep, loved unconditionally? I can't keep myself from wanting the closeness, a heartache deep down that is. Is it nostalgia, the longing, or just seeking connection to life's blood? Breathe in, fresh and cool. Breathe out the heaviness. I keep breathing. That I can do. Life force, prana, energized by air and lighting my cells with oxygen. That keeps my metabolism moving along, processing in and out, synthesizing to sustain and renew. Oh, if I forget how to breathe, or if I cannot breathe on my own driving force, I will let go, I hope, without fear. Move from this to another place, perhaps? Father of osteopathy has told us the body is a second placenta, and placentas are to nourish and to support the unborn. So when I am no longer breathing, I'll move on, the cord severed, and step into a world new and different, a different realm. That scares me, but the alternative does not sound like a good option. Someone might need to remind me of this when my time comes. I offer my sincere gratitude to my teachers for letting me be with you, and some teachers who have moved on. To the founder of osteopathy, Andrew Taylor Still, and the DOs who continue to model his genius and inspiration. To my patients, their families, medical students, residents who make this work meaningful. And special thanks to my patient L.M. and my mother, who were both more than happy to have their stories included and gave me permission to include their images. Gratitude. My email address, if you have questions. Again, I was telling you that I'm going to be with my mom to celebrate her birthday when this is being aired, so I may not be able to answer questions in the chat box. I'll try. But please feel free to email me or call or text. Well, if you text, tell me who you are, so I might not answer. So email is probably better. And I have a list of references of all the wonderful articles and books that I have been able to get my hands on. Thank you so much. And we will be having a lab following this, and I'll give you some suggestions and reminders of how to treat our older patients. Thank you for attending. Stop my share and stop recording.